time domain OCT3 and the spectral domain Artivue. And again, you can easily see the differences in detail. And once again, I'd like to point out how well the choroid is viewed. It's becoming clear that the choroid and measuring the choroid may be important in certain diseases such as central serous and also perhaps in macular degeneration. So again, comparative speeds, 400 A scans a second versus 26,000 A scans a second, 10 microns resolution versus 5 microns. And because of the speed of the spectral domain machines, they can get a B scan faster than a human can blink. So how does this translate to better patient care? What are the clinical advantages? We can now precisely register one OCT from one visit to an OCT to a future visit. So you can know that you're always imaging the same place from visit to visit. Now, for many of the diseases that retina specialists treat, that may not be so important because when a macula is very thickened, if the registration isn't precise, you'll only be off maybe 10 or 20 microns out of 600 microns of thickness. It's very important if you're measuring nerve fiber layer because the precise amount of nerve fiber layer difference as glaucoma progresses may be small. And I think in the future, when we are treating diseases such as dry macular degeneration, very small differences in thickness are going to be very important. And so registration is going to be very, very important to us. Complete data sets, there's no interpolation necessary with the raster scanning of the macula. These machines allow you to do three-dimensional imaging. You can get beautiful videos from them, and I'm sure you've seen them, and I'll show you a few in this talk. I think from a clinical perspective, the videos are mostly important to show the patients. Patients really like to see them. They're not so important for interpretation of the disease. There's no software for motion artifacts because of the speed, and again, I talked about resolution also. The Artivue machine is able to do oversampling, which means you can do multiple B scans in the exact same site to get one image. And there is software that oversamples and it reduces spectral noise to give you a better image in that one plane. Anterior segment imaging is available. A virtual fundus image is available from a 3D data set. And other ancillary tests are also available as part of OCT packages. Now this also comes with disadvantages. First of all, if you raster scan the entire macula, the data set is very large. Some of the raster scans can take 3 to 4 seconds to obtain, and it's difficult for a patient to sit still for that long, especially elderly patients. Even if you get this very large data set, it's hard to know how much of it's important. A raster scan of the macula can contain over 1,000 V scans. Is 1,000 V scans important? Is 800 enough? Is 500 enough? The studies that have been to show how many V scans are enough in any of these images still hasn't been done yet. So we don't really know how much raster scanning is necessary for these clinical images. These machines don't do as well with small pupils in some cases, and especially medial opacity can produce a shadowing. Spectral domain OCT also has some specific artifacts that you won't see with time domain. The one that's most important for retina is the mirror artifact, which is shown here. I'm sure you've all seen this if you've imaged highly myopic patients. And this is easily recognized, and it doesn't usually have any clinical importance, but this is only seen with spectral domain. Reflection artifacts are more important for the anterior segment imaging. Other disadvantages, if you switch from a time domain machine to a spectral domain machine, what do you do with the old data? How does it transfer? The cost, these are clearly more expensive. If you do multi-center clinical trials, there are multiple machines available. So if you have one type of spectral domain and the person who's in the trial in another city has another spectral domain machine, how do you produce similar data? This has not yet been worked out. So what about these multiple systems? How come there was only one time domain machine, but there are multiple spectral domain machines? And the answer is that it doesn't appear that spectral domain technology is patentable. And that's why you see now up to 9 companies worldwide selling spectral domain OCT. So how do you tell the difference? And the bottom line is the hardware between these machines is not that much different. It's really the software that will allow you to scan patients rapidly and accurately and get the information that you really need to know. So the differences are mostly in the software. So on to the Optovue machine in particular. These are the details of the Optovue machine, 26,000 scans a second, resolution of 5 microns. And here are some of the real clinical advantages that we found using this machine. First of all, real-time scanning. You see an image of the patient's fundus in real time up on the screen. And that's very helpful if the patient has fixation losses or does a lot of blinking, because you can see whether the image is high quality or not in real time. This machine was the first one to offer retina, glaucoma, and anterior segment imaging all in one machine. And the normative database for glaucoma and for retina is the largest that is currently available. It's also race-specific, which is important, obviously, in a country like Brazil, where there are people of many different ethnic backgrounds. I mentioned the averaging, and this is an averaged image. Again, the frame averaging means oversampling in one particular site many times, and the software averages out the noise. Comprehensive database we mentioned. Another unique aspect of the software is the ability to create specific scanning protocols. So if you want a certain protocol or a series of protocols for certain patients, for example, if you have a patient with a macular hole and you always want your photographer or imager to do an EMM5 plus a line scan, you can program a macular hole image into that machine, and every time that diagnosis comes up, those are the 2 scans you will get. And obviously, if there are certain scans you like to do for certain disease states, that speeds up the process. The individual scans for each patient can be optimized by inserting the patient's eye color, their refraction, and they have also a setting for either vitreous pathology or chorioretinal pathology, which changes the gain if you want to see the vitreous better, if you're dealing with disease like macular hole or vitreomacular traction, where you really want to image the vitreous. All of the OCT machines will allow you to segment the entire full thickness of the retina, from the internal limiting membrane to the RPE. The Optovue also automatically will segment the inner retina, the outer retina, and the pigment epithelium. The software to evaluate the scans is unique for the Optovue. The Optovue allows you to look at elevation maps and deviation maps. The deviation maps can be deviations from normal or deviations from previous visits. Also, there are progression maps. Since the scans can be registered from visit to visit, you can see the change over 4 previous visits automatically with the software. If you're interested in symmetry between the 2 eyes, that's again more important for glaucoma than it is for most retinal disease. That can be done as well automatically. Threshold volume measurements. If you want to see how much of the retina is thickened above a certain level that you choose, suppose it's 300 microns, the machine will automatically give you a color map to show what part of the retina is above 300 microns. So if you feel anything below 300 microns is in the normal range, you can very rapidly see how much of the macula is normal using this threshold volume measurement. If the software makes a mistake and the segmentation line is not accurate, you can redraw the segmentation line automatically. There are multiple options for 3D imaging, multiple glaucoma scans, and of course anterior segment imaging as well. For those of you who are thinking of getting a machine or don't have a lot of experience with it, setting up the original scan, there's some things that are important to do. The refraction, it asks for the patient's refraction. That takes a little time to input it, but it makes the focusing much easier if you input the refraction. Choosing eye color also helps. It will speed the scanning. I mentioned the vitreoretinal versus chorioretinal setting. most of the time we